Hello everyone, and welcome to another CB Clips. In this week's CB Clips, I present you with a premature baby transferred to you for a presumptive esophageal atresia. Now, many, if not most, concluded that this is not likely to be an esophageal atresia and suspected a perforation. And this is a very important clinical principle in our field. Esophageal atresia is usually not difficult to diagnose, but the potential one exception is in a premature baby where a pharyngo-esophageal perforation can be a great mimicker of esophageal atresia. And the characteristics of these patients is that they're severely premature. They've suffered some traumatic intubation or multiple instrumentations of the upper aerodigestive tracts. There's usually some blood in the drainage tube. And the position of the tube on X-ray is either too high, too low, eccentric, not in a correct location, or quite variable, as you see in this patient. Now, I actually suspected the diagnosis in this patient, which I took care of many years ago, more than 15 years ago, and did a study, as some of you suggested, but could not prove a perforation. You see, the study just shows a blind-ending esophagus. I reluctantly took this baby to the operating room, and after exploring the chest, I concluded that the esophagus was intact, there was no atresia, and shot another contrast in the operating room that now showed the leak. And this is, again, an important principle. You may not be able to prove a leak on contrast study, and you just have to suspect it in the correct setting, such as this. In this baby, I simply left the chest tube, treated the baby with antibiotics, and the esophagus completely healed. Since then, I've had several patients in whom I make the diagnosis based strictly on presentation, treat them with antibiotics, check 10 days later, you have a completely intact esophagus. So I hope you enjoyed this CB Clips, and until another episode. Thank you.